Well, good afternoon, everyone, and welcome to the Health Equity Jam session for today, May 25th, 2022. We're glad that you all have made time to be with us today. We know that this is a difficult and a somber day for us because of the tragic events of yesterday, and here we are again. We find ourselves mourning as a country due to another act of violence, and this time, targeting young children. When we thought that we actually had seen the last of such a thing, it's been a decade already since the last similar type episode. But as you all know, we're continuing to see this, and I know that there could be a tendency among us to just sort of despair and wonder if it's ever going to change. But we are the ones that are going to make the change. And that's what we just have to remember, is that we are the ones that will make this change if we continue and if we persevere and we continue to work together. So that, in the spirit of that, and in the spirit of our being united as a community that cares deeply about those who cannot defend themselves and those who are struggling with, the injustices of our society that have led them to hopeless places, this means our work is even more important today. So with that reminder, we're going to persevere, and we're going to continue to celebrate one another and support one another and grow in our work. And that's what we're here for. So we're pleased to have today, our speaker is Dr. Somnath Saha, and I'll give you a formal introduction to him, and then I'll do our more informal and fun introductions that we do as part of the Health Equity Jam session, because it's just become a part of who we are, and so we didn't want to disappoint you. And I hope you enjoyed the music, by the way. Feel free to drop any comments in the chat about the music and the song, and any thoughts you have about that. I enjoyed that. I think our speaker appreciated our selection as well. And maybe he'll tell us more about that later. But anyway, so Somnath Saha is a physician. He's a health services researcher here at Johns Hopkins in the Division of General Internal Medicine. He comes to us from the Oregon Health Sciences School, where he was on faculty for many, many years. And he and I go a long way back. I'm not even going to tell you how far back we go, but I think we were presenting together in a session probably more than 20, 25 years ago, maybe even more than that, where we were talking about this very topic that he's going to be presenting about, because he and I are kindred spirits in that both of us have a shared passion for improving relationships across racial and ethnic differences, and basically understanding more about what creates the disparities that we see in interpersonal treatment for people of different social Black backgrounds, or groups that are minoritized due to their race or ethnic identity. So Tom's going to talk about his work in that area. But meanwhile, we need to take a few minutes to learn some things that we might not know about him. He has a lot of other things, accomplishments, national awards for his commitment to diversity, equity, and social justice in healthcare. And he's been just a national treasure. So we're very lucky to have him here at Hopkins with us now, and here in the Center for Health Equity as one of our core faculty, I might add. So, okay, enough bragging about Som. But then, well, some of you may have gotten a little clue about him from the music we heard, but maybe you might want to take a guess at what one of his secret indulgences might be. I'd love to see some ideas in the chat on that. And let's see what we got there. Okay, somebody said Taylor Swift. So great choice. We made it sort of easy for you, or either that or you were like eavesdropping before we started. What else? Where does Sam hail from? I told you about Oregon. So was he born in Oregon? Let's take a guess as to where he was born, but also maybe another secret about him. He was not conceived and born in the same country. So let's take a guess as to where he was conceived and where he was born. Guesses? Let's see. I mean, this guy is really something. He travels while he's in utero. Okay, somebody said, oh, Gia says she thinks you were born in Korea, Sam. What about that?
Never actually been to Korea, but
never been there. Okay, but you still could have been conceived in Korea.
I could have been.
Were you? No.
No.
Okay, well, people are saying he was born in the US. Okay, born in the USA, born India or Bangladesh. Nah, well, no, not really. But we're getting closer. So conceived in.
Oh, that's interesting.
Oh, somebody says Singapore. Okay. Well, that's closer than Korea, I think, right? Born in UK. These are good guesses. Conceived in India and born in the United States of America. What state, though?
Oh, am I divulging?
Yes.
Yes, I was born in Ohio. I would have been born in the UK, but my parents changed their plan last minute. They were supposed to go to a residency in London, as were all the top Indian medical school graduates. But they got a tip that
freezing a little
there
bit.
Was less anti-South Asian racism in the United States. Am I freezing?
A little bit. Yeah.
Sorry, am I frozen? Oh, I'm sorry. I will just apologize that we are, Comcast is basically doing work in our neighborhood, so I'm on a hotspot. Yeah, so it's unfortunate, but it's a safer route than having the internet drop out in the middle of the talk. So.
Right, no, I understand.
Okay.
Well, I happen to know that if you had gone to UK, you would have been born in the same country your wife was born in.
Right. I actually, before we got married, I had to vet her because I said, like, I can't marry someone who's, oppressed my people for hundreds of years.
Oh dear.
And she pointed out that she was actually Irish, so she was oppressed by the same regime.
Oh my goodness. Okay. All right. Well, now that you guys got that straight, I'm glad. Oh. Well, let's see, what else? Let's see. He has a connection to someone who is famous. And so can you guess which famous person was a frequent visitor at Sam's home when he was a young person? President Obama, okay. I don't think he was in Ohio, was he?
No, I think President Obama was a young person when I was a young person, so.
That's true. I mean, I forgot. President Obama is like one of our cronies, isn't he?
That's right.
We're sort of in that same generation. LeBron James, okay. Well, let's give them a category of famous. You want to give them a category?
So the person is a musician. The instrument that they're most famous for playing for, most interest.
Prince.
Most famous for playing was featured, I think, on the intro song. The instrument. I don't think the person himself was.
I did hear it. People weren't listening that carefully, huh?
No. It was a little bit of a funky song to associate with this particular
That's
conversation.
true. But I heard it at the beginning. I thought, wow, this is kind of an interesting song. It has an ethnic sound to it.
Mhm.
Do you want to divulge, Sam?
I'm getting a question. It's a male.
Male, yes.
Male, yes. He is from,
Ah,
oh
got
my,
the ding, 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 ding.
ding, ding, ding.
We've got a correct answer there. Ravi Shankar.
Ravi Shankar is Bengali. My family's Bengali. And when he used to be on tour in the United States, he often played St. Louis. There was which was where I grew up. And there's a fairly large Indian community there. And he used to, whenever he came to St. Louis, he would basically ask my mother to make her fish curry, because when he was on world tour, he missed his cooking, and my mother made a special type of Bengali fish curry. And so Ravi Shankar would come to our house. And I remember when I was 8 years old, my mother and father pulled me in to meet this world famous person, and I didn't know who he was, said hello, and then went out to play with my friends. um, but now I do remember it. So I do remember hanging out for, a brief 30 seconds with the most famous sitarist in the world. So.
And then he becomes one of your fun facts. So.
That's right.
So I see there's a Nora Jones lover. So lots of people appreciating that very talented family. Well, there's another hobby that Sam has that, if he hadn't gone to med school, this is what he would be doing. So let's see some answers in the chat, and that's going to be your last question for the fun facts. So what would Sam be if he wasn't a physician and a health equity researcher? A guitarist.
I wish. Oh God, I totally wish.
Soccer player. Okay. Great thoughts. Yeah. Painter, comic writer.
So good. I wish I could be any of these things.
Yeah. Do tell, fashion designer. Oh, Sam, you really have, people have all kinds of ideas for you.
I know. I mean, these are all I'm Hindu, so I could, we believe in reincarnation. I could do all of these things.
Well, so. I think this reason, this thing that you would have done if you weren't a doctor could be one of the reasons my friend married you. There we go. Something on that order, right? Tell us about your culinary skills.
Yeah. And when I was a third year medical student, I realized that it was assumed from the age of 2 years old that I was going to be a doctor, because both my parents were physicians. I grew up in hospitals, and everybody basically assumed I would be a doctor. I assumed I would be a doctor, and I never questioned it. Went all the way through college, not even questioning it. Got through the first 2 years of medical school, which are basically like college. Got to my third year of medical school, where I had to see patients, and I freaked out because I thought I wasn't good at this. And then I thought of I kind of had a moment of crisis where I thought maybe this isn't my shtick, and I almost dropped out of medical school. I had a stack of culinary school applications on my desk. And then at some point I had this epiphany that I could be a chef with an MD, and it would be stupid to stop with 1 year left. So I continued, I finished, and then the rest was history. So.
Well, thank goodness. I mean, where would we be if you had decided to do that? Well, I mean, we would probably be having an amazing time, but we would have lost out on your amazing talent in this field. So I'm glad you decided to stick with us, and we can still come over for dinner sometime. So, well, without further ado, I am going to turn it over to you, Sam, so that you can give us your talk, and we can have a lively discussion.
Okay, well, thank you, Lisa, for the introduction. Thank you for having me. I just sort of want to remark that, in addition to the tragedies that have befallen us in the last couple of weeks, today turns out to be the 2-year anniversary of the murder of George Floyd. And I guess it's worth, sort of taking a moment. I think that was the moment when I think this country seemed to wake up to the idea that we live in a racist society. The concepts of structural racism and bias became kind of more mainstream and accepted. And I'm going to talk about, how this affects the doctor-patient relationship. Obviously, there are more dire consequences to the way that racism manifests in our society. But I think, as Lisa mentioned, she and I have been doing work in this space for a long time. And, the more everybody does to chip away at the effects of racism on whatever our purview is, I think the better. And that's sort of what motivates my work. And in that vein, I'm going to basically kind of tell the story of my, my work in this area and how it started and where it's come. My disclosure slide, there's some funding from different sources, but nothing that represents a conflict of interest. So this story of my interest in this topic begins back, I'll just, I guess, date us. It was the sort of the mid 1990s when there was basically a flood of studies that were coming out in the scientific literature, showing that people receive different healthcare in our healthcare system in the United States based on their race and ethnicity. So basically, every month, almost in the mid 90s, there was a paper in JAMA or the New England Journal showing that we basically deliver care inequitably across racial and ethnic groups. And at the same time that this was happening, that there were basically, there was evidence being produced that we have inequitable healthcare delivery. There was this other thing happening. This is when I was in residency training, and I trained in San Francisco. And in the mid 90s, around the same time, there was a citizens initiative to ban affirmative action in the state of California, and it passed. And liberal California became the first state to ban affirmative action. And then I moved from San Francisco to Seattle to do my fellowship. And while I was doing my fellowship, there was a citizen initiative to ban affirmative action in the state of Washington, which passed. And then liberal Washington became the second state in the country to ban affirmative action in hiring and education. So at that point, I was sort of afraid to move anywhere else, lest other state ban affirmative action. But what was being talked about at that time was what kind of effect this policy would have on the clinical workforce. So, and this was a study that a colleague of ours did, looking at sort of what happened to medical school matriculation in these two states that banned affirmative action before and after. And the numbers don't look dramatic, but these numbers should have been these slopes should have been increasing. There were lots of campaigns to increase the number of Black, Latino, Native American physicians in the United States. And in the wake of these affirmative action bans, the numbers were going down. So we were basically kind of losing ground on being underrepresentation in medicine. And this was on top of, so this was basically, we were losing ground on this phenomenon, which is that we had, kind of gross underrepresentation in the physician workforce. among Black, Hispanic, and American Indian populations. So this was back in 2000. You can see that about 21% of the US population at that time, or 26% of the US population at that time was Black, Hispanic, or Native, but only about 9% of physicians. So these groups were underrepresented to the tune of less than 50% representation in our profession. And so I became interested in the idea that there might be a connection between disparities in healthcare delivery and disparities in the healthcare workforce. So the narrative is that among white patients, most saw physicians of their own race. They tended to get more care and higher quality care. Among Black and Latino populations in particular, few of them saw physicians of their own race. Race or ethnicity, they received less care and they got lower quality care. So, was there a connection between the disparities in the workforce and disparities in that we saw over and over in healthcare delivery? So I had the opportunity this is my postdoctoral fellowship project, to look at this, to basically see if I could tie these things together or see if there was a connection between these two things. And so I did a study looking at race concordance between patients and physicians to see if basically if there was a connection between the race of the doctor and the quality of care the patient received. There was a national survey done by the Commonwealth Fund, which is a nonprofit based in New York City. They had done a national survey oversampling. It was a random digital telephone survey. They oversampled people of color, and on that survey, they asked people, as a lot of surveys do, to identify their own race or ethnicity, and then they asked them what the race ethnicity of their regular doctor was. And then later, elsewhere in the survey, they asked them to rate the regular doctor, they asked them to rate their overall health care, and then they asked them some questions about whether they got the care that they needed. And so one thing that we found in the survey was that people tended to see doctors of their own race, disproportionately. So across the board, you can see the red bars represent the proportion of those groups, white, Asian, Black, and Latino, in the US physician workforce. And then the blue bars, it was the percent of patients in those groups seeing a doctor of their own race. So you see the blue bars are higher than the red bars across the board, which means that patients tend to see doctors of their own race, regardless of what their race is, more often than expected. And this we found to be pretty dramatic. So you can see that Black physicians, Latino physicians make up about 5% each of the overall physician workforce, but somewhere between 25 and 30% of Black and Latino patients saw physicians from their own racial and ethnic background. So basically, there was just a large disproportionate matching of minority patients with doctors of their own race. So then we looked at sort of, does this matter? Does this affect the, patient-physician relationship? And this is what we found, is that for Black patients in particular, there were sort of consistent effects almost across the board. So Black people in this survey who had a Black physician who had a race concordant physician were more likely to have chosen that physician, to say that, I chose my physician, as opposed to, I didn't choose. They were more likely to rate that physician as delivering excellent care. They were more likely to say they received all the preventive care they needed and all the care they needed in general. Latino, we saw one significant effect with Latino patients. They were more satisfied with their healthcare overall. We didn't see significant individual effects in the other categories. So this was sort of like, a kind of a test of concept. We were looking at whether race matters in the doctor-patient relationship. And this was my very first study. I presented it in the same session that Lisa presented a study on race concordance at the National Society of General Internal Medicine meeting. That's where we met. It was exactly 25 years ago, Lisa. And It turns out that Lisa and I published our studies basically simultaneously, and they became the first two studies of patient-physician race concordance in the medical literature. And we've been friends ever since. After we published these studies, a bunch of other studies sort of followed suit. And a few years later, I was asked to do a review of the race concordance studies out in the literature. And basically just to sort of show that this is not, this was not just a one-off. There were a fair number of studies, and most of the studies showed that there was a race concordance effect. We categorized studies as looking at utilization of healthcare, quality of care, and outcomes. And there were mixed results. Not all studies found a concordance effect, but the majority did. And the majority did, particularly for patients of color. So there seemed to be a signal that race concordance matters in the doctor-patient relationship. And then the question became sort of why? Why does race concordance matter? What's driving this, this finding? And this basically gave rise to the next 20 years of my research career. So before we get to why race concordance matters, I think we have to sort of get into sort of why does race matter, and kind of an understanding of what race means. So this is the sort of a definition of race that I use to sort of frame how I think about this concept and this variable when I'm doing my research. So I'll read it. It's a system of subdividing humans into groups based on physical features and geographic heritage, aka continental origin, that is used, that was designed and is used primarily as a mechanism to justify social hierarchies, oppression, segregation, and the distribution of power and resources. So I think it's important to sort of, kind of clarify the definitions that we use, because I've found in speaking, with other physicians, other people in academia who are not, versed in race and racism, that a lot of people sort of think of race as the first half of this definition, a system of subdividing humans into groups based on physical features and geographic heritage, period. And that's how people think about race. And that is why I think, in the medical profession, we tend to biologize race, because that is the part of the definition that we kind of adopt. What most, I think, physicians and people in academic medicine don't understand is the second half of this definition, is that this is where race came from. Race was, race was designed as a concept. The construct was created basically to justify white supremacy. The evil genius of the concept is that it was mapped to continental origin, and so it was sold to us as sort of this marker of ancestry. And I think most physicians and most scientists, non-social scientists, tend to use that definition of race. Basically, it's a proxy for ancestry. And I've found that when you tell people race is a social construct, they kind of look at you funny, like they don't understand it, because what they've kind of understood race to mean is this first half of the definition. But really, when I use the concept of race, I think people always say race is a proxy for something. It's a nebulous construct. It's always a proxy. I think at its root, it is a proxy for the experience of racism. Racism is, as I show here, a schema for organizing society that uses this concept of race to impose, rationalize, or maintain unequal status. So in thinking about why race concordance matters, how race affects doctor-patient relationships, this is the frame by which I'm viewing race and racism. So with that in mind, race concordance, or let's just flip it and say race discordance, can affect the way we deliver clinical care, or the way doctors interact with patients in different ways. And these are, I think, the three most commonly posited ways in which race affects doctor-patient interaction. So I'll start with probably the most commonly posited mechanism is through cultural differences. So we live in a a racist society where people, grow up in different neighborhoods due to segregation. People have different experiences, and that gives rise to people kind of having different cultural views of the world. And so there's this hypothesis that what impedes relationships between doctors and patients across racial and ethnic boundaries is cultural differences, that people who are Black, Latino, Native have different cultural perspectives and ways of being than that they're predominantly white doctors, and that leads to worse interactions. So my colleagues and I had the opportunity to sort of address this hypothesis in one of the studies that we did. So we did a study where we were looking at doctor-patient interactions in an HIV care setting. And in our survey, we included a measure of what we call cultural dissimilarity. So we asked patients to rate on a scale of very similar to very different, the degree to which they and their doctors spoke, reasoned about problems, different manifestations of the concept of culture and how it might affect doctor-patient interactions. This was a scale designed by some of our colleagues to kind of capture this idea of cultural dissimilarity in the doctor-patient relationship. And so, they could basically, they could have a score from anywhere from a low of 1 to a high of 6. And so what we found is, we surveyed a little over 400 patients from a variety of HIV clinics across the country. And what we found was that there was a sort of very slight increase. There was a very slight, slightly higher score on cultural dissimilarity for patients of color. So Black, Latino, and Asian patients generally felt a little more culturally dissimilar from their doctors than white patients did, but none of it was actually statistically significant, and the numbers were fairly small. You can see they all hover around 2 on a scale of 1 to 6. And when we looked at whether cultural dissimilarity is associated with any markers of people's experience or outcomes of care, we found that that the more culturally dissimilar, the less patients thought of their healthcare, the less they trusted that doctor. But that effect was similar for non-white patients and for white patients. So the bottom line message here was that cultural dissimilarity probably matters in the doctor-patient relationship, but it doesn't seem, at least in this one study, to be playing a large role in explaining disparities between white and non-white patients. So another pathway by which race discordance might affect doctor-patient relationships is what I call the social distance hypothesis. Basically, we live in a racist society where people live sort of in different spheres and different strata, and people who live in the lower strata might kind of have greater levels of discomfort or distrust with especially institutions like medicine because of power differentials and discrimination. So the idea here is that independent of anything we do as clinicians, patients may sort of hold us, patients of color, especially those that have experienced racism and discrimination, may hold us at arm's length, and that may affect the quality of our relationships. So I did a study to sort of test this hypothesis. This was a sort of an experimental study where it was a vignette study where I basically hired actors to portray physicians, and we gave them a script, and they basically read the exact same script, and we varied the race, gender, and age of the physician. the physician actor. And so basically the idea here is that, we wanted to keep the message the same and vary the messenger and see if that made a difference, to test this sort of idea of like whether people, given the same message, trust certain messengers more than others. And in this case, basically, this was the scenario here was that the doctor played a cardiologist. They were explaining to the patient they had just had a coronary angiogram because they had come in with chest pain and that they needed bypass surgery. And in the Q&A, if people want to pick my brain about why we picked that scenario, I can tell you all about it. But a lot of it was about, studies that have shown pretty wide disparities in cardiovascular procedure use, and it also being a high stakes procedure where you really need to trust your doctor in order to accept the recommendation. So we then took these videos and we randomly assigned people. We went to pulled people out of a waiting room at a hospital, and we randomly assigned them to see one of the videos. So that we didn't show them multiple videos. Each one got one, so that we kind of hid the intent of the study. And then we asked them a bunch of questions to rate the doctor, and also to what they would do if they were the patient in this video. Would they accept the recommendation for bypass surgery? So what we found is that for white patients, the messenger didn't really matter. And this is what we expected, is that basically, white people in the United States don't really have to think that much about race because they're, kind of at the top of the hierarchy. It doesn't, and we weren't, this is what we expected, is that the race of the physician wouldn't matter in terms of how they rated the physician. For Black patients, we found that it mattered sort of across the board. So when for Black patients who saw a video with a Black doctor, they rated the doctor better in terms of every aspect that we measured: communication, interpersonal style, competence, trust, comfort. Basically, they just gave the Black doctor a higher rating, and this was with the exact same kind of script and mannerisms, and we hired actors so that they could keep everything very standardized. Again, when we looked at decision making, would you accept this recommendation, etc., we found that for white patients, there was no difference between the white doctor and the Black doctor. For Black patients, there were significant differences. They were more likely to perceive bypass surgery as being necessary. They were more likely to say that they would have it if they were the patient in this video. They were less likely to say that they would get a second opinion. They were even on rating the risks and benefits, which we thought was reassuring because we gave them the same exact risk benefit information across all of the videos. So then again, this was sort of another test of concept to say, like, is there, of the social distance, independent of anything the physician does, is there a greater distance for Black patients coming into the visit from a white physician than from a Black physician? Is there less trust, a priori? And I think this, we kind of concluded that there is. I can't see the chat, Lisa, so if I am happy to be interrupted, but I think.
Yeah, there was just one question about how large the study was, and I think that was the study before this one, the one on cultural dissimilarity.
Oh yeah, on the cultural dissimilarity. Right, there were about 430 patients in that study. And they were in 4 different cities across regions of the US. So the last pathway by which race discordance, I think, is hypothesized to have its effect is the idea of race bias. That I think everybody's familiar now with the concept of race bias, and the idea is that we may harbor biases that lead us to treat people unequally, even in an unconscious way. So race biases, you all probably know, the Asian groups with positive or negative qualities, manifests as negative feelings or judgments, which we call prejudice, overgeneralized beliefs about an individual, which we call stereotyping, and the differential treatment, which we call discrimination. And as you know, it can be explicit, which is conscious and intentional, or implicit, which is unconscious and automatic. Now, the measuring unconscious attitudes and bias is very difficult. Luckily, there were some clever social psychologists who many years ago developed something called the race implicit association test, which I think many of you are probably familiar with and have taken. Basically, it's a video game where you are shown black and white faces and good and bad words, and you are asked to sort them with the E and the I key of your computer to the left or to the right. And basically, we measure bias by the degree to which it takes you longer to sort black, African American faces with good than African American faces with bad. And it turns out that most people in this country are faster at associating European American with good than they are with sorting African American with good. We tend to sort of cluster African American and bad and European American and good faster than the opposite. And it turns out that there are plenty of studies that show that the microseconds longer that it takes us to do the sorting is a reflection of our unconscious attitudes. And there have been several studies to validate that this actually does translate into the way we interact with people from different racial backgrounds. So, and basically this, the way that the implicit association test is scored is from -2, which is a strong implicit preference for blacks, to +2, which is an implicit preference for whites. You can see the typically observed range of scores goes from a slight pro-black bias to a moderate to strong pro-white bias. Basically, the majority of Americans have a pro-white bias when they've taken this test, and they've done this test on, I think, now tens of millions of people. They've collected data. So, then the question is, do physicians have bias? And it turns out, yes, we are human. We are like everybody else. And there have been a variety of studies that have looked at whether physicians, how physicians score on the implicit association test. You can see that physicians in general have a moderate to strong pro-white bias on average. And that is true across the board, except for Black physicians who tend to have a neutral, not pro-white, not pro-Black. But everybody else is pretty pro-white biased. We, I think of ourselves as an altruistic profession, and we have sort of, kind of sometimes have negative views of lawyers, but lawyers actually seem to have a little less bias than us, at least on a population level. PhD scientists also. So we as physicians are, on the kind of more biased side of different professions. So is there bias in clinical encounters? Does this manifest? So, this is a hard thing to study, but about a decade ago, Lisa published a study, I think really one of the only studies that's looked at, directly looked at bias and how it affects clinical encounters. This was published in the American Journal of Public Health, and you can see I'm not going to show all the data because it's complicated. But the conclusion supported the paper is a clinician implicit race bias and compliance stereotyping. So they use two different forms of the implicit association test. Are associated with markers of poor visit communication and poor ratings of care, particularly among Black patients. So basically, kind of, again, sort of validating the idea that bias does affect, our implicit biases do leak out into the way we interact with patients. So we did a study to sort of look at another way in which bias might leak into clinical encounters. And this was a study, we did a study not for this purpose, but then we actually stumbled upon this other manifestation of bias in the clinical encounter. So we did a study where we recorded a lot of doctor-patient visits, audio taped them, and we coded them to see how doctors responded to patients' emotional concerns. So patients gave sort of expressed emotions, and we looked at sort of how doctors responded to those emotions. And we were just looking to see, it was sort of a descriptive study, but we had, patient race in our data set. And these are different ways that physicians can respond. They can be neutral, they can acknowledge the emotion, they can explore it, they can express empathy, they can give advice, or they can just block or ignore, basically divert attention from that emotional concern. And what we found was that there was a fairly large and significant effect where doctors were more likely to block or ignore the emotional expressions of Black patients compared to white patients. We were sort of not expecting this finding. We weren't looking for it. But we found it. And so we happen to have another data set, a separate, and basically we repeated the analysis. We did the same exact study in a different sample with different encounters, and we found almost an identical result, basically an adjusted odds ratio in the low, 2 to 2.5 range, statistically significant. So basically it was a consistent effect, and it was a little bit shocking. We weren't expecting this. So again, this sort of suggests that probably, I suspect that physicians aren't intentionally, knowingly blocking the emotional expressions of Black patients, but across two different studies, they were doing it. So another finding in our qualitative work that we've done that sort of validates this idea that we block and ignore Black patients comes from, this is a study that we did where we were basically asking people from different racial and ethnic backgrounds about the meaning of respect in healthcare interactions and the experience of respect or disrespect. And there was this sort of troubling but very consistent finding that Black patients in particular, not Latino patients, not white patients, not Asian patients, but Black patients in particular, very commonly brought up this issue of being dismissed. And you can see these quotes here. You know your body when you come in a position of being in control and know yourself. You cannot tell me there wasn't nothing wrong. I mean, I feel like that's disrespect. At the bottom, we know, like I said, we know what's wrong with us. We know what's hurting, whether they want to believe it or not. And we saw just a lot of comments like this of basically patients feeling like they were being dismissed and not believed. And coupled with this idea that, this other study that we found where patients were, kind of being blocked or ignored, it seemed to be sort of a consistent kind of finding. And I think this is a way in which, our bias kind of leaks into our interactions with patients. So, then when we started looking around, we found that this issue of being disbelieved was not just, we thought like we'd stumbled upon something really remarkable. And then it turns out that, this is just, among Black people who go to doctors, this is not this is kind of a pretty common experience. So this is a social activist based in Chicago, and Xavier Raimi, and he was interviewed by the Chicago Tribune about bias in medical care. And he said this: 9 times out of 10, I was completely brushed off. If there was ever a book on medical racism, it should probably just be called They Don't Believe Us. So it was sort of, kind of triangulation that, we found it in our study. This activist in Chicago that we did not know was basically saying it. And it turns out that this concept of being disbelieved has gotten some attention in the philosophy and ethics literature, and has been labeled with the term testimonial injustice. And testimonial injustice is defined as when a speaker receives an unfair deficit of credibility from a hearer owing to prejudice on the hearer's part. So this is basically described by a philosopher named Miranda Fricker. And so, testimonial injustice is, people think, oh, it's just a matter of like whether you are believed or not. But testimonial injustice can have some serious consequences. It's a common phenomenon in law enforcement. Some of you are probably familiar with the story of the arrest of Skip Gates. Skip Gates is maybe America's most famous African-American studies professor. He's sort of a celebrity. He's on the news all the time. And an incident where he was trying to get into his own house in Cambridge, Massachusetts, and he and his driver were basically, the door was stuck and they were trying to get in their own house, and someone called the cops because two Black men were trying to get into this house, and the cops came. The cops asked for his ID, asked him to prove that he lived in this house, because they didn't really believe that he lived in this house. And there was sort of like Dr. Gates started yelling at the man and was then taken in. Obviously, abuses of Black men by the police have become incredibly commonplace. But this was sort of a direct, I think, consequence of the phenomenon of testimonial injustice, where, this person was not believed when he was entering his own house. So then the question is, are these testimonies that we've heard from patients, examples of testimonial injustice? Do people will say, and sometimes they don't even say, but you can tell that what they're thinking in the back of their head is, is this really, are people really being disbelieved? Are they so sensitized? Maybe Black people are so sensitive to the idea that they might be discriminated against that they're sort of, gives rise to the term perceived discrimination. Is it really discrimination, or is it just perceived discrimination? So, people will sort of say, is this really happening? And it turns out that, we've sort of tried to see, is there a way to prove that testimonial injustice is actually happening in clinical care? And it turns out there's a smoking gun, which is the medical record. So my research partner, happens to be my wife, basically several years ago stumbled on, when doing kind of a different project, was reading the notes of patients with sickle cell disease and was kind of just appalled at the stuff she was reading. And we started talking about it, and we realized that the medical record is a place where we sort of just, as clinicians, let our biases flow. We sort of see the medical record as a place where we can let out all our frustrations. And so when we started looking, we saw that there was evidence that, what people were telling us they experienced was actually being recorded. So these are straight from actual clinical notes. Patients reports 10 out of 10 pain, but labs are stable. So it's sort of an implication of there's doubt there that the patient's pain is real. Claims the nicotine patches don't work for him. So, the use of the word claims, sort of implies disbelief. Reports unbearable pain, but cervix unchanged. Sort of these ways in which basically we cast doubt on things that patients were saying. So we then wanted to see, is this a systematic phenomenon? Is there evidence of testimonial injustice in the medical record? So we set about basically looking for markers of doubt that land in the notes of patients in medical records. And we categorized different ways of expressing doubt. So we looked for the use of discrediting verbs and adverbs, like claims he still has pain, insists her pain is not improved. So these were sort of doubt words. Reportedly had 2 seizures. And then we looked also at the use of quotes that are often used to cast doubt on a patient's testimony. So states his pain is still 10 out of 10. Now, you're just basically reporting what the patient said. So the quotes are basically there just to say, I don't believe that the pain is really 10 out of 10. Patient had a quote reaction to the medication. There's really no reason to say that the patient didn't have a reaction to the medication. The quotes basically say, I don't really believe this is a true reaction. So these are just ways in which we can sort of express that we doubt the patient. So then we looked and said, do we find that these markers of doubt are more common in the notes of Black patients compared to white patients, and we found that there were. So basically, if you look over to the right, the Black-white difference in the use of discrediting words and quotes was, it was basically, we used discrediting words and quotes more in the charts of Black patients than white patients, and both of those were statistically significant. So statistically significant. So basically, this was a study to suggest that, it's, what patients are saying, that they're experiencing testimonial injustice in the doctor-patient relationship. At least the medical record bears out that they are probably right. So then there's a broader literature on just the way we talk about patients in the medical record. This was a study done by colleagues of ours at the University of Chicago. They looked for stigmatizing language in the medical record. They looked at a lot of these, a bunch of negative descriptors, and you can see the list of words that they looked for here. And they sort of hypothesized that we use these negative descriptors more in the records of Black patients compared to white patients. And they looked at Latino patients too. And basically what they found was that, yes, we use stigmatizing language more often for Black patients, and to some degree more often for Latino patients than for white patients. And so we might think sort of like, okay, well, this is just medical record stuff. It's probably wrong, but, is it that consequential? And so we did another study a few years ago looking at the impact of stigmatizing language. This is another vignette study where we were trying to see, do clinicians make different decisions based on what they read in the medical record? So, the medical record is a way of just recording our notes, but as clinicians in the audience know, we read other people's notes and we formulate opinions about that patient, even without knowing it. We formulate opinions about that patient based on what we read. So we did a vignette study where we basically had two different versions of a vignette of a patient having a sickle cell pain crisis. And we took stigmatizing language directly out of real notes from medical records of patients seen here at Hopkins. And so over on the right is a snippet. We had a whole it was a longer case, but this is one little snippet. He's insisting that his pain is, quote, still a 10. His girlfriend is lying on the bed with her shoes on and requests a bus token to go home. So sort of gratuitous information that really has no, clinical purpose. And then we sort of washed the stigmatizing version and said, here's what could have been said that have been less stigmatizing. He still has pain rated 10 out of 10. His girlfriend is by his side, but will need to go home soon. So then we took these vignettes and we randomized medical students and residents to these two vignettes. Now, what we did is we then surveyed them about sort of their attitudes towards that patient using a scale to measure attitudes towards patients with sickle cell disease that we had developed previously. And we found that the students and residents had more positive attitudes towards the patients who had neutral language describing them as opposed to stigmatizing language. Then we asked the residents to say how would they treat the patient. So basically the scenario was this patient's been treated with such and such medication, opioid medication, what would you do next? And we gave them a bunch of choices, and we basically created a score based on the choices we gave them. And again, basically the residents gave more pain medication to the patient who was described with neutral language than stigmatizing language. So this was sort of kind of our way of showing, like, the way you actually write about patients actually might affect the care they receive from the next physician who sees them. So, our conclusions were that language of the medical records can basically reflect our unconscious or even conscious biases, which may be unrecognized by the author. So we may not even know that we're writing these things in a way that's biased. It may perpetuate stigma that influences subsequent clinicians who care for the patient, and it may reflect or perpetuate testimonial injustice, particularly for Black patients. So these are, I think, sort of, I've gone through sort of the pathways by which race discordance can affect doctor-patient relationships and interactions. And this is sort of another a model of how I see, this happening. So basically, racial differences can even before the patient and provider interact at all, racial difference can create a social distance just because we live in a racialized and racist society. And then, if there's cultural dissimilarity or race bias, that can actually increase the amount of distance between the patient and the provider. The distance between the patient and the provider then has sort of consequences for the relationship. The greater the distance, the less effective the relationship, maybe the less trusted the doctor is, which impacts patients' decision-making and adherence. And that in turn can affect health outcomes. So this is all by way of saying, this is how I conceive of race affecting doctor-patient interactions that may actually contribute to disparities in the quality of healthcare and in health outcomes. So then the question is, sort of how do we bridge the distance? When I showed you the video vignette study, one thing I didn't show you was sort of a second step in our study, which is that we varied the communication style of the physician. So in addition to varying the race and gender of the physician, we varied their communication style. We had each of the actors do two different versions. One we called low patient-centered version, the other we called high. And you can see the parameters that we varied. So the amount of patient participation that was elicited, the affect of the physician, whether it was neutral or businesslike or kind of more warm and friendly, lay language versus more biomedical language, information giving high and low, empathy high and low, and eye contact. So we varied these versions so that we could see what would happen if we make the communication style of the physician more patient-centered. And this is a little bit complicated to look at, but what we did then was since we saw a concordance effect for Black patients, we wanted to sort of look at whether the concordance effect diminished if we infused a patient-centered communication style. So the blue bars is the disparity between the Black physician and the white physician. It's basically the blue bar is the concordance effect if there was a low patient-centered communication style. The red bars are the concordance effect if there was a high patient-centered communication style. So, and basically the biggest difference is over to the right. So basically what we found was that even the red bars are all significant. So there was still a concordance effect, even when we, kind of made the communication as good as we could. Race still mattered, but it mattered a lot less. So basically this was kind of the message here was that you can diminish the concordance effect. You can reduce the social distance imposed by racial differences between doctor and patient by using a more patient-centered communication style. Another way that I think we, can sort of bridge the distance is through, something that psychologists call individuation, which is simply investing in knowing the patient as a person. So when we know the patient as a person, it can, first of all, bridge interpersonal distance by finding points of connection. So you can basically kind of find commonalities between you and your patient. It has the potential to reduce stereotyping, because when stereotyping is basically knowing a person as a member of a group. Knowing a person as an individual reduces the likelihood that you are going to categorize that person by their group status. And then it can also increase awareness of social context and determinants of health, because you basically know about that person in their life. And this is a study that Mary Catherine did many years ago. She's looking at the sort of just the power of individuation, where she had the opportunity to ask patients whether they felt known as a person by their healthcare provider. And the answers were no, that the person, this doctor doesn't know me as a person, I don't know, or yes. And she found a graded effect where basically the more known the patient felt, the more likely they were to be on appropriate antiviral therapy, the more likely they were to be adherent to that therapy, and the better their viral loads. So HIV turns out to be a a very nice model for studying the effects of doctor-patient relationships, because adherence leads directly to a better clinical outcome. So another sort of avenue towards reducing distance is we found in studies that I've done the idea of valuing patients' perspectives. So we developed a lot of sort of attitudinal scales about how doctors view taking care of diverse patient populations, and we tried to look at which of these attitudinal scales predicts greater equity in care. And the one that we found had the most signal was this one, which we called our Valuing Diverse Patient Perspective scale. You can see what the individual items in the scale were. They're basically about kind of partnership, believing, sort of wanting to hear about your patient's perspectives, understanding their social circumstances. So, for lack of a better term, it was sort of an open-mindedness scale, an equity-oriented scale about, sort of reducing power differentials. And so what we found was that, when we looked at, so this is a study where we asked patients to rate their providers on these 4 things at the bottom, give them a global rating, rate them on communication, interpersonal style, and trust. And we stratified the doctors into doctors who scored low on this VDP scale, Valuing Diverse Patients Perspective scale, and people that scored high. And what the bars show is basically, this is a difference in different studies. So it shows the black-white difference in ratings of physicians. And what we found was that basically for doctors who had were low on the scale of Valuing Diverse Perspectives, they had significant disparities across the board in these ratings. Doctors that scored high on the VDP scale, there was no significant disparity between Black patients and white patients. So basically, doctors who scored high on this particular scale had more equitable, their relationships were sort of more equitable across Black and white patients. Doctors who scored low, basically, did fine with their white patients and didn't get great ratings from their Black patients. So, and this was sort of, the Valuing Diverse Perspective sort of is in line with the idea of testimonial justice is, do you believe your patient? Do you value their opinion? Do you take what they say seriously? And, we've presented this stuff about testimonial justice and valuing diverse perspectives to, community members. And there was, a little bit of eye rolling, you spent a lot of time proving the obvious. And this particular testimony kind of grabbed us. It says, if you want to build trust among Black patients, trust Black patients. Sort of said it better than we could have said it. And then finally, I think, there's recommendations. We have recommendations for medical record language. So I think, I think we can't fault people for the way that they document medical records. I think blaming is not, a great way to correct behavior. But I think we can tell, I think if we make people conscious of the way that we're documenting and the way that we're characterizing patients, we can go a long way to sort of reducing basically the propagation of racism that goes into our notes. So we can avoid propagating negative stereotypes. We've seen tons of examples of just quoting poor grammar in people who have lower levels of education, particularly minority patients, and there's usually no reason to sort of put in poor grammar when you're quoting a patient. We don't have to add irrelevant details that highlight stigmatizing characteristics, like, we've seen things like, the patient was sitting, with the example of the patient's girlfriend was lying in bed with them demanding a bus token. Like, is that clinically relevant in any way? I think we can curb our disapproval and frustration. I will say that, like, this is we often get frustrated with patients because patients can frustrate us. But I think we can sort of check ourselves. And before we basically put it in the record, I mean, it's like a rap sheet, the medical record. Before we put it in there, like think, like, is it really necessary for us to vent ourselves? Because the next doctor who sees this patient may formulate an opinion based on our kind of ranting. And then we can strive for testimonial justice, check our assumptions about whether this person is telling the truth or not. Provide context when documenting health behaviors. So like, for instance, non-adherent is the word we use when people aren't taking their medications, but often we just say people are not adherent. And then the next person basically that reads the record is sort of thinking, oh, okay, here we go. We've got a non-adherent patient, and they formulate an opinion about this person before they even see them. But that person might be non-adherent because they can't afford their medications. They can't get to the pharmacy on time, and so we basically, kind of pile on the disadvantage of disadvantaged people. We can avoid discrediting words like insists or supposedly or claims. And I think, should just avoid using quotes to indicate disbelief. Quotes have a role in medical records to sort of, characterize what patients are saying. I'm having, crushing chest pain like an elephant sitting on my chest. That's a clinically relevant way to, and appropriate way to characterize patients' testimony. But sometimes we use quotes, what we call scare quotes, to basically kind of show that we don't believe what patients are saying. And finally, I'll just say that, the elephant in the room is that we still have, a woeful lack of diversity in the clinician workforce. So I showed you back in 2020 what it looked like. It actually is worse now. The degree of underrepresentation has basically, the proportion of the US population that is Black, Hispanic, or Native American has increased. The proportions who are physicians have basically stayed level. So underrepresentation in medicine is even worse than it was 20 years ago. And given the disparities that we see, and given the connection between disparities in the workforce and disparities in healthcare delivery, this is a problem we really need to put our full force behind. So I will stop there and thank you. And I guess, Lisa, if we have time for questions, I'm happy to.
Sure.
Thank
you very much. There have been a lot of positive comments in the chat about how great a talk it is and how important the topic is, and how exciting your work is. So thank you very much. And I think there were some questions that came up that I tried to answer based on what I know, but one of them was related to whether there was a difference between physicians in different geographic areas of the country, North versus South, and whether there was a difference between men and women in your results.
Yeah, so the question of geographic differences, it's a great question. I think the meaning and impact of race is obviously different in different parts of the country. We haven't done a ton of reporting on this because with our studies where we're using, like, for instance, in the studies where I've done studies where I use specific VA medical centers, and we've done studies where we use specific HIV clinics across the country. We promised that we would not divulge like who they were. And you can sort of tell from the author list which clinics we're talking about. Yeah. So we tend not to report by geography. Yeah. I will say that it does, when we do it internally, I will say that there look to be kind of, at least, our numbers get small because these are primary data collection studies. If we're doing 400 patients, then it's 100 per site, and then the numbers get a little small to detect differences. But yeah, I'll just suffice it to say it does look like some places look worse than others.
Yeah.
And then with regard to the women, the gender story is very complicated. It's not so straightforward. It turns out that, in a nutshell, what a lot of studies in the social sciences have shown seems to be applicable to the way people perceive women physicians, which is that women physicians often are held to a higher standard. So male physicians, if they, for instance, in our patient-centeredness study, when we varied patient-centered communication, the male physicians kind of got neutral ratings when they had a low patient-centered communication style, and they got really positive ratings when they used a patient-centered communication style. Women got neutral ratings when they used a patient-centered communication style and low ratings when they didn't. So women were expected to be warm and fuzzy. Men got credit for being warm and fuzzy. So that's basically how it played out. And women were worse critics of women physicians than men were.
Right. So that's like kind of the gender concordance piece, right, Sam?
Yeah.
I know my study sort of smaller sample too, but the women tended to have a little bit lower race bias. Mm-hmm. When it came to gender, I agree. Women get sort of rated worse by gender concordant interactions, indicating that people were sort of holding them again to a higher standard, like you said. But yeah, lots of complexities with this, right? And a lot of intersectionalities of identity. So that's another issue to think about. Another question that came up was related to whether you had expanded this research to gender and sexual orientation of providers and patients, or language. And, we know that there's some work going on in that area, but I don't know if you specifically want to talk about yours.
Yeah, it's not, that is not, I think Lisa and I have colleagues who do work in those spaces, and it's not our area of expertise, or I haven't done a lot of research on that particular issue. There's study on language concordance. I mean, this is truly proving the obvious. We have to prove the obvious with data, because otherwise people will just sort of question whether it's, it hasn't been documented that it's not true. So, but people have thankfully proven the obvious, which is that if you're speaking a different language to the patient, you will have worse interactions and outcomes. So luckily we do have colleagues who work a lot on language concordance interpreter services. And, those studies fairly clearly show that language concordance between doctor and patient trumps everything. Good interpreter services then are next, and then sort of, language discordance generally is, associated with the lowest quality of care. And then in terms of sexual orientation, I think that's just sort of an emerging literature. Part of it is that there's, even in the race concordance literature, it's hard to do large studies because of the paucity of underrepresented minority physicians. So, Lisa did I had to do my study with sort of a national survey. Lisa did her study as a primary data collection, Black physicians in the Baltimore, DC area to collect. But, in terms of sexual orientation, it's hard to find those data. We don't collect those data either for physicians or for patients
right.
on a routine basis.
Right. So you can imagine it would have to be a study in which there was a lot of safeguards put in place to protect people from loss of confidentiality or, discrimination, actually, frankly. So when people are sort of more willing to report that information, it might be collected in a primary data collection study, but like Sam said, it's not something that is going to be readily available in any medical data set. Mm-hmm. Somebody did mention generational age ratings, and I'm curious to see what you've seen about that, Sam.
Yeah, I think when we've analyzed our data, the age has not been a strong, the age of the physician has not been a strong predictor. And it's in empirical settings, it's often difficult to look at like patient perceptions of looking at age, often because older physicians, patients often have longer relationships. So that basically, when you look at age, you're often dealing, you have to adjust for how long they've been with that clinician, because the longer someone's been with a clinician, sort of, the more positive the ratings tend to be. Right. But in our study of, the vignette study, where we didn't really vary their age, but we varied sort of what their age appeared to be. We didn't really find any differences across the age strata.
Right. Yeah, I mean, there is so much more work to be done, but so much progress that has been made actually in the field. So it's rewarding to see, how your work, also mine, has actually led to changes in medical education, changes in the approach to like even continuing medical education now, and policy changes, too. So, requirements for certain kinds of training to be physicians to undergo certain trainings, even though we know that we still have a lot of work to do to figure out like, well, what training actually is most effective. At least we know like what we're aiming for in the training in terms of the patient-centered communication style, the individuation behaviors, things like that. Somebody was asking about how do we get CMS to reimburse for individuation, which I think is a very, provocative question. Like, some of these things are hard to capture, to measure, and doesn't mean that they can't be measured, but that's one way to push for policy change, right? Is you have to, if you don't measure something and you don't know what it is, you can't reward it, right?
Yeah, I mean, I think so. It is like, I mean, I do sort of preach based on my own research to trainees, for instance, that people ask sort of, how do we be anti-racist in clinical care? And what I will say is that from my own work, there are a couple of ways that we can sort of be anti-racist. One is that we can advocate for race-conscious policies that basically increase representation of underrepresented minority physicians. So that is basically, affirmative action is an anti-racist policy. And, the term anti-racist kind of showed up on everybody's in everybody's consciousness just a couple of years ago. But affirmative action is basically a policy that says we will basically affirmatively take into account the racism that people experience, so that we can correct, basically repair the discrimination that is faced by people of color. The other thing is that people will, I do basically argue that we should spend time on individuation, and we may need to spend more time on individuation for people who are from disadvantaged groups. And that, if we want to be equitable rather than equal, if we want to be anti-racist rather than non-racist. So if you basically treat all your patients the same, you are non-racist. But that doesn't mean you're anti-racist, because you are basically just keeping the status quo, which is racist. So if you want to repair, call it medical reparations, if you will, but you will basically spend more time, individuating and, establishing rapport and investing in the relationship with a person who is at a greater social distance from you based on racism, sexism, any kind of discrimination. Now, as with reparations, nobody's willing to go there. Like, the idea that CMS is going to pay you more to take care of a socially disadvantaged patient. I mean, I think that doesn't mean we can't stop trying to do it. I mean, we do there are ways to sort of say, we have a code now for, we have a ICD-10 code for this person is affected by social determinants of health. If you consider racism a social determinant of health, you click that button, and then you get basically that code goes in, and that might affect the way you get reimbursed for that patient encounter. But I think it is, it's a little bit like interpreter services. Like we don't really get any more money for, even though it takes us gads more time. So there, I think, but these are the things that I can now, as like, at least now, since the summer of 2020, we can at least talk about it. Like we used to get laughed out of the room if we even mentioned this kind of stuff. But I think now we can at least talk about it and start lobbying for it.
Right. So a couple of questions and more questions in the chat. Barbara Batista, I think, is saying, does the BFRSS evaluate any of these things? I don't think so, but you could maybe chime in on that. And then there's another one on how is work like yours being disseminated to inform policies and continually influence provider-patient relationships?
Well, you can answer that too, Lisa. I mean, I think like so I will say that I try to work with people that or organizations that might be able to influence. I've worked a lot with the AAMC, which sort of has a lot of influence over medical education policy. And I've tried to sort of make them aware of like the work that I've done, and I think they have used it in some of their guidance. So I was on a group at the AAMC. I was on their holistic review project advisory committee, where we were basically giving guidance to medical schools about using race in admissions decisions, for instance, and I was able to sort of infuse my work into there. I think basically that you have to basically, I think if you basically put things on people's desk, you'll make a little bit of change. If you actually get on committees and then are able to sort of show them your work, you make more change. So yeah, I don't know what you think about that, Lisa.
Yeah, I think we've come a super long way. I mean, the AAMC, the LCME, the American Board of Internal Medicine has questions like this now as part of a recertification module. Where we have a lot more work to do is with the payers. But I mean, I think it's hard to get the payers behind anything that's not a real concrete, like biological measure or something that isn't linked to costs. So I think that's a lot of what our hurdle is. But I don't want to keep people too long. I know it is 4:30. Let's see, another comment to Dr. Saha from Sabu Ramalingam. Fantastic presentation. He's the lead quality for Care First. One of the things he's curious about is how payers can cooperate with physicians and health systems in research. And so we would love, we should save your comment, Dr. Ramalingam, and we'd love Dr. Saha and I at the Center for Health Equity to talk more with you about that. And
yeah,
just
we're out of time, maybe just shoot an email and we can talk offline.
Please feel free to connect with one another outside of this forum. We're breaking for the summer, but we will be back in September. Stay in touch with us. Stay strong, stay healthy, and we're so thrilled that you were able to join us today. And thank you again to Dr. Saha for an excellent and invigorating, exciting, enlightening presentation.
Thank you, Lisa. Thank you all for being here.
Thanks, everyone.
Thank you. Bye-bye.